run through some stuff that you might see. Just take this as part of your break and just relax for a moment, because you've all seen all this in the textbook. So take a deep breath and just relax while I show you some key changes in diabetic eyes. Okay, right, so everyone tell me what I'm seeing here. This is the retina, and these are?
Not sharing.
Oh, thank you so much for that. Right, here we go. Let's share that screen.
Okay, got it.
Okay. This is the retina, and this is our anterior retina. Globoid bodies are part of clinically cotton wool spots. Okay, because you know that cotton wool spots are caused by constipated neurons. There's a lack of axonal flow. So here we go. They just bung up like this.
Can you go presentation mode?
I sure can. There we go.
Yeah.
Right. So this is what cotton wool spots look like, and they're quite different to hard exudates, which you will know are very deep. This is really out of focus at high power, right? So they happen in the outer plexiform layer mainly here. This is a little subretinal exudate happening here. Okay. Now you'll notice this has gone all pink. That's because this slide has faded over time. It's really, really rare to get decent diabetic changes down the microscope. And this is the one in the Crvo cloud thing. But you'll see again these hard exudates here in the outer plexiform layer, and the subretinal exudate here, and the photoreceptors have all broken down. Right, out of focus, sorry about that. I've taken these from books. Hemorrhage, look for hemorrhage. This is again from the Crvo cloud, look particularly in the choroid for hyalinized vessels, right? And look here for bits of gliosis. So you recognize the bits of gliosis because the outer nuclear layer disappears. Now these are probably burn marks because we've got RPE proliferating through here, okay? And through here, it's been torn off, maybe artifactually here. All right, here's another little burn mark, right? Hyalinized, smooth collagen around this thick-walled vessel, characteristic of diabetes, right? This is another characteristic of diabetes in an arteriole this time, this thick-walled arterial subretinal exudate. Right, and you'll see this in the Crvo cloud. So there's actually neovascularization here, which is tearing off the limiting plate of the nerve fiber layer. Okay, so here we have it, another one. So here we've got a vessel which is looking less hyalinized. We've got subretinal exudate here, and then why have I shown this one? I'm not sure. Maybe because there's very mild gliosis through here. Gliosis can be a bit subtle. This is the nerve, and anything you see stretching across here suggests that there might be some neovascularization. Neovascularization, as we've learned, is really hard to spot. This is a tiny vessel, and the easiest thing to find is the hemorrhage. Notice also up here we've got this Brooks membranes become really hyalinized as well. Here we've got another little burn, right? The gliosis, the loss of the outer nuclear layer, the proliferation of the RPE. They're very characteristic. Moving to the front here. Okay, so this was a post-mortem eye, I think, so there's been some degeneration, but this is the lacy vacuolation, and it's quite prominent rather than the one or two vacuoles that we had before, right? So quite a lot of lacy vacuolation. We've got iris here that might have a new vessel on the front of it here because it's really, really flat. Okay, so that was just my reminder of what you're going to look for when you're looking at the slides. Okay, I'm going to stop sharing the screen now, and we're going to start looking at the slides. Is there another question? A cytoid body, thanks. Cytoid body is the name of those things in the
globoid bodies. That's the
cytoid. Cytoid body in the
soft cotton wool spots.
In the cotton wool spots. Okay. Right, should we look at some slides? I'll pause the recording. Okay. All right, so Amanda, do you want to amend the chat again? And
Yes, I will do the chat.
okay, before we start actually looking at the slide, how did you find that one?
Yeah, post some questions or you can just ask them directly.
Just observing. I'm observing people becoming faster and much more confident in looking at the slides. I've been really impressed by people integrating their clinical and histopathologic knowledge. So they see something and go, oh, is that because they've observed it quite a lot clinically. And that's the skill that we're really, really going to try and get you up there, because you are expert diagnosticians.
All right, so question, help with gliosis recognition, please.
Okay, so there's two things that to look for. The first is disruption in normal structure. So on the previous one, I was showing you how there was a nice outer nuclear layer, which suddenly, poof, was gone. And it was replaced by cobwebby material. Okay, so gliosis looks like cobwebby material. It is the scar tissue of the neural tract. So if the normal structure's gone and it's cobwebby, gliosis. The other place that you can see gliosis for sure is in long-standing retinal detachment. And you'll see that in the long-standing retinal detachments, there's kind of the wavy look of the retinal, like, come off thing. And then the nuclear layers start getting all a bit jumbled up and fuzzy, and there's this cobwebby stuff, and that's gliosis. So just recognizing that there's loss of the normal, nice linear nuclear layers.
Thank you.
Okay. I'll share screen. Okay, so this was the globe. I'll make it big. All right, okay. Right, low power questions, Amanda.
No low power questions yet.
Okay, let's just point out some stuff at low power that I hope you noticed. I hope you noticed the gorgeous, gorgeous ectropion here. Look, does it curl around? So lovely, ectropion uvei. And there's a really very long stretch here of anterior synechiae. This is where the epithelium has come off from the underlying cornea. So this was normal and this is artifact. At the front of the lens here, did anyone notice that there was this lovely fibrous cataract? Can't see it at low power, but if you go to medium power, we can see that. Moving around the back here, I don't think I could see any burn marks. I didn't get to looking at high power in this bit, but you look for them where the retina appears to be tacked down. Okay. The retina is separated here. There's nothing in between, so we'd have to look at the photoreceptors. I can see loads and loads of cystic edema all the way through here, except back here, probably around the macula, and there's the optic nerve that wasn't sectioned. So those are my low power observations. What are some questions, Amanda?
No more low power things. Do some high power questions.
Yeah, those are the high power questions.
Cytoid bodies.
So I couldn't see any cytoid bodies. Did anyone think they could see cytoid bodies? No, I couldn't see any hard exudates either.
Mm.
Okay.
No more questions yet. So.
Okay, so if you do see ectropion uvei and the iris nicely tacked down, you know there absolutely must be new vessels on this iris. So that they must be there. And you can just see them here. They're the little ones on the front, right? 1, 2, 3, right? Because remember, the normal iris vessels are these big jobs in the middle. Moving backwards here, was this tacked down by burns? Let's have a look here.
And also a question from Cam, is the inferior retina atrophic where it is attached, which is exactly where you are?
Yeah, so the inferior retina here is definitely abnormal, right? Because we don't have the normal structure of the retina. Mm. Where is the inner and outer nuclear layer? And so yes, there is proliferation of the RPE here. So probably they've lasered this eye in this region, and it looks like they've it's carpet bombing along here. The other thing that makes me wonder, because it's not patchy, is maybe this diabetic person has had blockage of an artery. Okay, because essentially this retina is all dead and disrupted along here.
Would you call it atrophic or gliosis?
Atrophic, ischemic, and gliotic is probably that. So because it's such a long stretch of disrupted, I would maybe go with the ischemic and gliotic.
What are the white holes?
The white holes are the edema, so they're the fluid that is showing clear. Okay, let's go and look at this retina. Yeah, so this retina, complete destruction here of any of the normal kind of architecture. Maybe the branch artery that occluded.
Is the attractional retinal detachment?
Okay, so there's definitely retinal detachment, and there's definitely a ton of new vessels here and an epiretinal membrane through here.
How do we know it's retinal detachment as opposed from artifact?
Good. So we look at the photoreceptors to see if they're intact, and we look to see if there's any fluid here. So there's no fluid here. Oh, come on. A BAME slide, a BAME. Right. So it's going to render, and we're going to decide. I'm going to decide when it actually does a BAME. It reminds me of toddlers here, not obeying the master. We're going to decide whether or not it is intact here, the old photoreceptors. Yes, there's, I've just zoomed out so because I was getting tired of it not rendering. There does appear to be intact photoreceptors here, so we are going to call that artifactual. The epiretinal membrane starts about here, and there's lots and lots of vessels and fibrosis. And then it volcanoes out and produces this lovely chain of vitreal vessels. And then up here, when the rendering gets real good, you can see the wrinkling of the surface of the retina. That's really great.
Is the wrinkling a feature of the epiretinal membrane?
So it's a feature of, yeah, the neovascularization and the contraction of the fibroblasts. Anything else? I couldn't see any great vascular changes here in the choroid either, really. And interestingly, for this diabetic eye, they must have had good glycogen control recently, because there was no glycogen in the iris epithelium. Are we good?
Yep. And were there any cotton wool spots?
Could not see any cotton wool spots or any hard exudates at all.
In the ERM over the macula, can you tell that's the macula because of the ERM, or how else?
Yeah, so the nuclear layers are quite thick here, and plus it's right next to the optic nerve. Okay. So I would say yes, it was over the macula.
Okay, and a couple of iris questions. Where is the iris?
Iris.
Questions. What were the cysts in the iris stroma?
All right, let's have a look. I think they're blood vessels. These ones here, they're blood vessels.
No, just dilated blood vessels, yes. Without blood, that's why they look like cysts.
Yeah.
Yeah, tricky. Maya said they didn't see lacy iris. How common is it to see advanced diabetic retinopathy without lacy iris? Okay,
so the glycogen in the cells, I think, is quite dynamic. So it depends on how good their diabetic control has been recently.
Mm-hmm. Lens. Were the vacuoles in the lens suggestive of nuclear sclerosing cataract?
Whoa, okay. So I think there is a cataract here, but I think it's like just here anteriorly, we've got this fibrous tissue. And I think you guys know more about cataracts than me, actually. I think the nucleus, again, looks absolutely fine. There's a little bit of cleft and globule formation, but the thing that stood out to me was this anterior fibrous cataract.
Nishan says, is it fair to say that this eye has new vessels elsewhere because of the vessels in the posterior hyaloid over the epiretinal membrane?
Okay, I mean, it's definitely got new vessels in the iris and new vessels posteriorly. I couldn't see new vessels elsewhere, but you know, there's a big bunch of them through here.
And if so, is there an element of vitreomacular traction as well?
So there probably is some vitreomacular traction for sure, but we can't confirm that because we can't see. We can't see anything in this space.
Sam says, any defining features of diabetes versus CRVO?
All right. So apart from the URL, good question. Do you get epiretinal membranes in CRVO? I guess you do, don't you? Yeah. How about
so what about the, like I was asking about the basement membrane in the ciliary body, is that any help?
No, it becomes hyalinized in everybody over the age of 30. So the answer will be no. No. This is a...
So could you write that in the exam? Because like, would you just have to put your differentials and just your primary diagnosis?
Yeah.
Yeah.
And just say what's not there.
I suppose you wouldn't usually get an anterior subcapsular cataract with a CRVO, but.
And Nishan says, if there's lacy vacuolization in the iris, then does that mean it's diabetic?
So it means yes, they've had a high glucose recently. Yeah, diabetic. Yeah. Okay, I think we've discussed that one. I will stop sharing. And let's go. What's next? Okay, we've got this one that's labeled ARMD. Should we do that one and see what we can see?
Mm-hmm.
Great. I will put you all into breakout rooms again. Off we go. We're getting used to this now. Off we go to our breakout rooms, and I will pause the recording. Okay, so I'm switching the recording back on so I don't forget again. There we go. As everyone joins us back after looking at the slide. So good. That's a condition that we never see, do we, Amanda?
Oh, no. I noticed that the who's using Eagle as their text, and I noticed that Eagle's example of age-related macular degeneration comes from an enucleated globe for a tumor. So it's like an incidental finding.
So I think this was a post-mortem globe actually, because of the amount of like subtle degeneration in the retina, and someone kindly donated it.
Yeah, there's a lot of this sort of pulling separation.
Yeah, I think that's all post-mortem change. Yeah. Okay. How are we doing?
All right, good. So pose your questions now and through it, and I'll just pop them into Diane's tour.
Mark's asking, did anyone find drusen? I didn't find drusen. I'll share my screen.
Juliana and I found one tiny
one. Whereabouts was it?
Where was it, Juliana?
It was near the bottom.
Oh, here it is. Here it is. Yeah, I can see it now.
Oh, one little blob. Yes.
Yeah, there was a blob there. Yeah. Yeah, just there. Come on. There, right, when that renders, hopefully, I'm going to take my hand off the mouse, right?
Yes.
And just wait for it to render. I've got an eye mouse.
Oh.
Super sensitive. Anyway, somewhere around there was a little drusen just here. Oh, here it comes, here it comes. Come on, come on. It's like a racehorse. What's the next question?
Okay, so questions are coming in. How do we know if the pink stuff under the macula is fluid or scar tissue? Oh, yes, yeah, so that's when you get there. Chris says, we struggle to work out which retinal layer was which in the macula. That's a clue, isn't it? And where were the basal laminar deposits or basal linear deposits? And how do you tell the difference? I'm sure you'll cover all of those. Yes.
Okay. Right.
Anyway, we should be systematic. And
we'll go down to low power.
Start at low power at front.
All right. So not quite transpupillary, both angles open, and maybe a little tiny bit of change here that we'd go and look at in the lens, but no super obvious cataract. That just looked like a blob to me. There's a lot of separation here and separation between the layers of the retina, and I think that was due to post-mortem change. And then around the back here, we can see this nice subretinal scar. And the rest of it, bit of peripheral cystoid degeneration here in the retina. Otherwise, okay. Any other low power comments people want to make?
Mostly high power comments. In fact, all high power comments.
All right, let's have a little look at the scar here. Right, so how do we work out which layer of the retina is which? So I would suggest that you start outside an abnormal area and come in. All right, so outside an abnormal area. All pretty abnormal. So here I can see at least one nuclear layer. So I'm going to guess that that's the outer nuclear layer, inner nuclear layer, and ganglion cell layer, because it's most likely to have split along a plexiform layer here. So
you mean the split, do you mean artifactual, or do you mean
the artifactual split?
Yeah, okay.
There. And then here in the macula, we've got the ganglion cell layer, we've got the inner nuclear layer, and I think the outer nuclear layer has been largely destroyed by the scar.
Where are the photoreceptors?
So the photoreceptors have been destroyed as well, so they should be hanging off the inside. Let's come along here. They should be somewhere here, but we can't see them there. They're all destroyed. So how do we know whether this is a scar or whether this is fluid? Good question. So looking a tiny bit closer, we can see I'm going to retire my mouse. Here we go. Stay there. Right. We should be able to see in the scar tissue other stuff like vessels and fibroblasts, right? So you look at the scar tissue, we can clearly see that in there are little blood vessels, yeah, and some fibroblasts. And also the collagen here isn't just smooth, it's kind of got this wriggly structure to it. So it's got a collagenous wriggle to it. We can see the
so if it was
collagen.
Fluid, how would that be different?
Yeah, so fluid, so I thought there might be some fluid out this side here. I think this might be like organizing fluid out here, because here we've got the smooth homogeneous fluids and we've just got some new vessels kind of growing into it. And as we come around here, it's all smooth. So I think this might be fluid out here and not collagen. So that's the difference. So this is the fluid, smooth, uniform, no little blood vessels and collagen in it. And as we come around here, it's kind of organizing into the scar tissue. So fluidy stuff turning into scar tissue, proper scar tissue.
But that's why I was getting confused, because it looked different. I thought, oh, that looks like fluid and that looks like scar tissue, but then I thought they were supposed to be the same thing. If that makes sense.
Right, what was another question?
Also, we noticed that looking at the choroid there, the vessels are very prominent.
They're very congested. So I think the blood's all in the vessels, because I can kind of see the endothelial cells here. It is, the choroid vessels are all congested. They are.
Similar question, were there basal laminar deposits or basal linear deposits, and how do you tell the difference?
Okay, so I'm not that conversant with the histology of ARMD. You're probably better at it, having just read the book. So can you tell me what I'm meant to be looking for?
That was Chanel's question.
Yeah, so my understanding is with soft drusen, you can get basal laminar deposits, which are plaques of soft granular eosinophilic material that deposit on the Brooks membrane and elevate the RPE. And Moaz and I thought that we could see some just inferior to the field that you've got there. But we're not too sure how to differentiate them for linear deposits because the description is quite similar in the textbooks.
So we were having a look at basement membrane deposits a couple of weeks ago, weren't we, when you sent me that video, Amanda?
Oh, yes, that was in the epithelial layer of the cornea.
So were you thinking of that?
Yeah, just that amorphous eosinophilic, yeah, that little
The blob.
deposit there. The blob, yeah.
Blob, yeah, what is the blob?
What is the blob?
So I think that this blob is in a vessel.
It's in a vessel.
Those Brooks membrane, they're just underneath the RPE. I think this is like just fluid, like serum in a vessel.
Yeah, plasma stuff.
Okay.
Was there neovascularization present?
I couldn't see any. Couldn't see any neovascularization.
Can we tell the type of Cnvm looking at the slide?
Cnvm.
Chronic
neovascular membrane.
So I don't know what types there are because we never get them histopathologically. So tell me what types there are and I'll tell you if it looks like a variety. What are the distinguishing features?
I think type 1 will be underneath the RPE, and the type 1 will be breaking the RPE and going into the subretinal space. The vascular network of the.
So this one is at the bottom of the retina, and here the RPE, is it intact here? Let's have a look. Yeah, there's the RPE and Brooks membrane appears to be intact. Does that help?
Yeah, so yeah.
I found mostly the Brooks, the RPE was present, not lost.
Showing a bit of proliferation.
That's what we thought, Chanel, that could be type 1 where the vascular network is actually beneath the RPE. But
It's not beneath the RPE.
it's not.
No.
Nicola says, why did we think this is wet ARMD if we can only see one drusen?
So as in, I just meant there's obviously lots of differentials for subretinal fluid and subretinal hemorrhage. So if there's only one drusen characteristic of wet ARMD, why is this a drusen? Why is this an ARMD slide?
Partly because it was labelled that way.
Oh, okay. So it could potentially be another.
We never get to see it. So usually they're diagnosed clinically and then we get gifted slides. So this is a diagnosis that's made clinically.
That's probably a good indication there won't be a plethora of slides to take photos of for that portion of the exam.
No, I don't think so.
So do you not think there's like a fibrovascular mass in that main bundle of stuff? Because we thought we could see new vessels through there, but
Here?
yeah, in that area.
There are new vessels in here. There's new vessels,
Yeah.
and fibroblasts and collagen. And
That
then
would fit
up
with-
here there's fluid.
That would fit with like a fibrovascular network, which would be like a choroidal neovascular membrane, which is AMD, right?
Yeah, you guys have to answer these questions. I can make the histopathologic observations, but like,
Yeah.
hey,
I mean,
you guys know the patients.
Is
I
that
think
area of like fibrosis though, is that choroidal or is that subretinal?
It's subretinal.
Are the engorged choroidal vessels, is that CNVM?
I don't think so, because they're pretty engorged the whole way round.
Okay.
They don't look particularly neovascular. They just look
So,
regular vascular but dilated.
yeah.
So can you like specifically see the choroidal neovascular membrane there, or is it just the subfibrotic scar?
So I can just see this scar.
so we can see this as sub NVE then, but we don't know whether it's AMD or could be for, because the Cnvm could be secondary to other causes as well, like inflammatory or PIC or something like that.
Yeah, that would be a good thing to write in the differential diagnosis. This is a very, very clinical case where you'd have to bring your clinical info to it.
Yeah.
Yeah, so Cam's got a nice classification here. Type 1 is sub-RPE,
yeah,
which this is not, and type 2 is subretinal.
So this would be type 2.
Yeah, this is subretinal. Thanks, Cam.
Okay. Good discussion there.
Mm.
I've learned a lot at these sessions. I'm going to stop sharing here. And that brings us to the end of the session. So I will stop recording.